welcome to this MedWire News podcast for Medicine Matters Rheumatology. I'm Claire Barnard. In light of the current COVID-19 pandemic, rheumatologists are likely to have questions about the risk to their patients and how best to care for them. Featured in this podcast is Kevin Winthrop. Dr. Winthrop is Professor of Infectious Diseases, Ophthalmology and Public Health at Oregon Health and Science University in the USA. Dr. Winthrop is an expert in the prevention and treatment of opportunistic infections in patients receiving immunosuppressive therapies. He collaborates closely with the rheumatology community. So, Dr. Winthrop, could you tell me what your experience of COVID-19 in patients with rheumatic diseases has been so far?
Well, my personal experience here is zero. I mean, we've only got a couple cases where I'm at, which is good. But of course, we're preparing for much greater surge of patients, and that would likely include people who are using immunosuppressive drugs as well as those, with rheumatic diseases. Worldwide, there's not a lot of data yet. I mean, there's few to no case reports of those types of patients. We just don't know. So, it's an open question about, how much increased risk those conditions pose on their own, how much increased risk do any of the immunosuppressive therapies pose. In some cases, some of those therapies may be protective. We just don't know yet.
Do you think any of the rheumatic diseases in particular might pose a higher risk than others?
Not necessarily. I mean, maybe, I think, just when you think of infections in general, the more active a rheumatic disease is in general, the less robust the immune system is with regards to fighting a variety of types of pathogens. A lot of those have to do with diminished cell-mediated immunity, which I don't think would be, something to think about here with COVID. Humoral immunity is also dysregulated, and I don't know that would come much into play. I think that, maybe lupus versus rheumatoid arthritis versus, psoriasis. I mean, you can think of things where the immune system is maybe dysregulated to a greater degree, or there's more inability of T cells to do their jobs, for example, in one condition versus the other. But to be honest, I don't think we really know. And most of those people are on different types of therapies. So I think there's two things to think about. One, disease that's controlled versus uncontrolled. And I think uncontrolled disease likely poses a risk, not just for COVID, but secondary bacterial infections after COVID, as well as routine bacterial infections and opportunistic infections. We know all those things are more common in people that have less controlled autoimmune disease. So I think treating autoimmune disease is important, and achieving low disease activity is important, and that in itself is protective. Then the second question is really just which one of those drugs, if any of them, are problematic for people in terms of increasing risk of either getting, and there's really two concepts there, really, either increased risk in terms of getting COVID if you're exposed, and then the other concept is really having worse outcomes if you actually do get it. And those are kind of two separate ideas, and there are things, some of those drugs might be increased risk of getting it, but perhaps are protective of having a bad outcome if you did get it. So these are all questions that are going to need to be answered in the next several months. And I think, as we see more and more patients on these therapies get COVID, we're going to learn a lot more about how these therapies may modulate any of those risks.
So based on what's known about other infections in patients with rheumatic diseases, do you think there will be different risk levels with different drugs that are used? And if so, what do you think they might be?
Well, I mean, these are thoughts. Number one, JAK inhibitors have a known proclivity towards viral infections, but most of that is really due to the reactivation of latent viruses. We don't really know to what extent they increase the risk of acquiring new viruses. Now, we all assume that they probably do, diminishing interferon gamma signaling, interferon alpha and beta signaling. I mean, type 1 and type 2 interferons are part of our host system against viruses. So I would presume there probably is some increased risk. That being said, baricitinib, for example, also inhibits an enzyme that's involved in endocytosis, which is the way viruses enter cells and actually infect cells. So perhaps, people have theorized that perhaps baricitinib might be protective against infection because it's actually diminishing this kinase, this ADP2 kinase that is involved in endocytosis. So whereas the other JAK inhibitors don't have that activity as far as I'm aware. So, I mean, again, these are ideas. How these play out in real life, we don't know. IL-6 inhibitors, that's another good example. I mean, IL-6 is a very pleiotropic cytokine. The risk of IL-6 in infections probably depends on, the types of infections, but also really the timing. When are you inhibiting IL-6 relative to when the infection is occurring? And the risk might be different if it's early versus if it's late. So, for example, I mean, the cytokine storm associated with the sepsis and the ARDS associated with COVID, I mean, we are now trying to treat this with IL-6 blockade. So it may be that, at least at that point, that type of therapy is hopefully protective. I mean, there's studies ongoing looking at that question. But I think there's a lot of hope, and there's some early case reports that suggest it might be a good therapy for someone who is in the midst of very serious COVID-19 infection, i.e. they're critically ill. There's a lot of hope around non-biologic DMARDs, really specifically hydroxychloroquine or Plaquenil. I believe there's a trial of chloroquine in China, and I don't know of any hydroxychloroquine trials, although there might be one. I know a lot of people are using hydroxychloroquine empirically. There was some nice data out of France published last night, of a small case series of patients, but they did show resolution of viral shedding in people who were confirmed cases of COVID-19, and the resolution seemed to be hastened by hydroxychloroquine, and even more so when it was combined with azithromycin. So I think that's another therapy that a lot of people are reaching for. These are old drugs, and there's in vitro evidence and now in vivo evidence suggesting that there's some activity. So I think that's, I don't know of any formal trials going on with that approach, but I know people are reaching towards them in the clinic or in the hospital.
So for now, obviously we have limited knowledge at the moment, but in your opinion, what advice at present needs to be communicated to rheumatologists?
I think for rheumatoid arthritis patients or other patients with inflammatory autoimmune disease, I think the advice to patients is follow the guidance of CDC and WHO and your local public health agencies. All the guidance out there is fairly uniform, and it's good, and it's really meant to diminish your risk of being exposed to the virus. So in terms of hand hygiene and not touching your face and whatnot, and social distancing and staying home, I'm a big fan of getting outside, however, and going for walks. I really think patients should be doing that. Of course, they should be avoiding people when they do that, particularly sick people, but you can go outside usually in most places, go for a vigorous walk and still maintain a 6-foot distance from other people. So I think that's something people should focus on. In terms of what to tell the rheumatologist, I think it's an open question around a lot of these drugs as to whether they modulate risk at all. And again, I think it's really two questions. It's a risk of getting it, and it's a risk of having a poor outcome if you do get it. And some of these drugs may be different in their risk with regards to those two scenarios. So we just don't know right now. I think I would not advise stopping people's biologics or small molecule DMARDs in an effort to decrease someone's risk, because we don't know if it will decrease their risk, and it will, of course, increase the risk that they'll flare, which then increases the risk of using prednisone, which generally increases the risk for most infections, and probably viral infections like this, although we don't know for sure. So anyway, I think the rheumatologist and the patient should strive for optimal disease control, and follow the same recommendations we usually follow when patients develop signs of an infection. Stop the drug temporarily. Miss a dose if someone is sick. So I think kind of the same guidance would apply now as it always has until we learn anything specific about any of these drugs. And then I guess too, I think hydroxychloroquine, if you're on that, then it's probably going to be protective. So maybe that's a good thing. So I think the message to rheumatologists is to broadcast a message of prevention to your patients. Number one. Number two, maintain and strive for optimal disease control using whatever DMARDs you're using. And number three, stop them when patients have signs and symptoms of illness or infection.
Thank you very much to Dr. Winthrop for speaking to us and for highlighting the most important things that rheumatologists should be doing right now. Thank you to you all for listening, and I hope Dr. Winthrop's comments will be useful for your practice.